I agree with everything that Caroline and Rangi said, and I agree with everything that Joe said. And I looked at Joe's PowerPoint and went, oh, I was going to say all that. So I picked 4 topics to talk about, and to give some patient examples. So I'm hoping you're all going to nod and say, oh yeah, I had that man, or I had that lady. Sorry. Better? Nairi? Better? Okay. So I am the hip fracture coordinator. I'm also the fragility fracture registry coordinator, which came out this year. And I'm also the team leader for the FLS nurse for Tauranga and Whakatane Hospital. And then prior to that, which is a nice segue from Joe's talk, is I used to be the NAS coordinator, so you've got the non-acute rehab ACC service. So before all these jobs, I did that for 6 years at Tauranga Hospital. So rehab, getting people home from rehab was my job. So hopefully I do have a little bit of insight into the nursing of rehab patients. So I just want to promote, Jamie will be pleased, on our website we have you heard of hip casts and hip tips? So it's a great way to get 20 minutes of education in. It's lots of health professionals talking about lots of different subjects, anaesthetic after surgery, Sarah's talking about geriatrician things. There's lots of podcasts to listen to, that's the word, isn't it? That you can download them on Spotify. That's how I listen to them in the car. So have a look at that. And some of the talk that I'm doing today is going to go into a hip tip. That's coming up. So my first topic I thought is, what is the best thing for that rehab patient? And it goes with what Caroline and Rangi said. And I think knowledge is power. So we have the knowledge, whether you're a physio, a geriatrician, a nurse. I think we have the knowledge, and very often we don't share it. We don't tell the patient the journey that they're going to be on and how it's going to end, or what our anticipation is. So I get the best bit, because as the clinical nurse specialist, for the hip fracture registry, I can go and talk to the patient. I have time to print off the x-rays and show them what's actually happened to them, which is also a very kind of, oh, moment, I find. Oh, I've got that right down to my knee. Oh, is that why my knee's sore? Yes. Oh, I can walk on that. It's a big rod. And I find that's a very, sharing that knowledge of what we know, because we just go about our health routine, and we know how health works, and we know how the hospital works, and what time this happens and that happens, but our patients don't know that. So very often just sit in bed, because they're probably frightened of ruining the nurse. I don't want to bother the nurse, is a great quote from every patient. No, you should be bothering the nurse, and ask every question that pops into your head, or write it down in the magic booklet. So I think that's what, just showing them an x-ray shows them why they're in pain. They like to compare things with their husbands and wives. They like to compare if they've got matching sides, so now if they've got metalwork on both sides. Not everyone, some people go, oh no, thanks, I'm not interested, but that's okay. And I think it helps them mobilise, that early mobilisation. They can see that their broken bone is no longer broken because it's got that support, it's got the Meccano plate, as I explained, a dynamic hip screw. You've got a big screw and a Meccano plate, and that you can walk on that. So that kind of sharing of our knowledge that we keep in our brain, I think, is very worthwhile. And I also think probably some of the generation of patients that we're seeing now, the 80 and 90-year-olds, when their family went into hospital with a broken hip, they never came out, or they were there for 6 weeks, and then that's their expectation because nobody's told them otherwise. And then when you say 7 days with no rehab, Caroline, or 21 days, lots of families want to know, I found your 21, I will say, from 7 days to 21 would be our realm of getting you out the door. I just think it makes people go, oh, well, I could sort that out. And that's a goal straight away. Without writing it down on a piece of paper by the OT and physio, you've just gave them a bit of knowledge and a bit of power for them to move on. I'm going to talk about the magic booklet without dropping everything. So I was involved in the consumer workshop that Caroline was at, and I sat at a table with 6 lovely ladies who'd all had surgery in the last year from a broken hip. They'd either drove themselves there, or they'd got a taxi, and very capable. 3 of them was working in a charity shop. None of them knew what they had in their hip. I was like, oh, so what did you have done? Or the surgeons fixed it. Yes, but with what? None of them knew. That just blows my mind. How do you let somebody do something to you and not know? And we all knew, so the team would know what's been done to that patient. If you asked 20 health professionals who looked after that lady, we would all know. But the person that mattered didn't know. So I think sharing our knowledge is that powerful rehab tool for the patient. And I think also talking about going home and what that looks like. My favourite quote is, if I could bottle confidence and sell it back to you for $1, I'd be a millionaire. Because it's the first thing that scuttles wherever you fall into the dark corner, and it's the very last thing that comes back. And I often, share that with the patient, and I always say, once you go home, that first night in your own bed, which you think now you can't achieve, and then you'll throw the covers off in the morning and go, oh, Nicola, of course you can sleep in your own bed and manage, and then that little bit of confidence comes back. And I think, just sharing what all that looks like, and I understand as the clinical nurse specialist who pops in for 10 minutes and the nurse is on the floor go, yeah, she's got the time to do that. But I think just somebody in the team needs to share that, whoever that is. So that's my first one. My knowledge is power. My second one is listening to them, even though you go, oh, it's Mr. Smith. I don't want to go in there. He's going to talk to me for hours. And very often they say, oh, my hip's fine. It's my bowels I'm worried about, or it's my ankle when I fell and I've got a graze on it, or I'm worried about I'm worried about my wife and how she's going to cope, and my daughter's travelling down, and there's lots of other things where we're just focused on the hip, but actually there's lots of other things we need to listen to. So the patient and the lady said this. They know their bodies better than I do, better than you do. So if they say something's sore, oh yeah, that'll be because. Well, let's have a look and let's listen to why they think they're sore. And we've knocked their nutrition, their normal nutrition right off, so they're constipated and they feel a bit nauseous with the pain drugs. There's just lots going on for them that I think we should also listen to, as well as it just being, we should look at the patient and not the hip. I've got a couple of cracking examples of this. We had a lady that, 72-year-old ex-physio, who was looking in a handbag, and it was a Wednesday, and she was looking in a handbag, and she lived in a 3-storey house, and she pressed a lift, and she just walked out, and the lift hadn't come up, and she landed on the lift shaft, the top of the lift, and she thought, oh, I think I've hurt myself, and didn't have a mobile phone at that time, and thought, my family are coming to pick me up for my granddaughter's birthday on Saturday. So she lay there till Saturday, and they found her, and she was alive, dehydrated, and had broken her hip. As she came through ED, that's what she did, and she went and got her hip fixed. And she woke up and she said, I'm still not right. And nobody said, it's your hip pain, I'm still not right. 5 days later, a very wise geriatrician who sat at the back of the room said, we need a CT of this lady, and she'd also fractured her spine and she'd fractured her pelvis. And this lady, we just didn't listen to her, we just said the pain was from her hip. And I just think we should have listened to it. This lady was a 72-year-old physio. She knew what her body was telling her, and she knew that the pain just wasn't the hip, and she still had it, and she just wanted to know what was going on. Another example, she went home and she was absolutely fine, and she sued the lift company because there was an error, just the outcome. But yes, so amazing. Another patient I've got is, we'll call him Mr. G, and I called Mr. G at the 120-day follow-up to collect his data about his fractured hip, and Mr. G was angry. very angry. And he had unfortunately got admitted on day one of last year's lockdown. And so literally in lockdown, we get them in and we get them out. And he went. So me and Mr. G are very firm friends. And he's got my number, sadly. And I've talked to him lots of times, and he just wants somebody to hear his voice. That's all he wants. Unfortunately, the story for him didn't end well. His dynamic hip screw failed. He went and had a full hip replacement. He then fell and fractured his T11. So he literally swore at the staff when they tried to give him his cluster infusion for his bone protection medication, but we got it in him 11 months later because he understood the process. He didn't know what was happening to him, so he said no. And actually he then went, oh yeah, that all makes any sense, Nicola, and we'll have it now. So I just think sometimes we don't listen because again we're in that hospital environment and that routine and we're just jogging along. We just jog along because we know how it jogs along, but lots of patients don't. My third one actually, is just to normalise that environment. So what we've all talked about, pyjama paralysis, get your clothes on, get ready. Nobody wants to sit in a hospital gown with your backside flopping out, like nobody. So why are we making people do that? So I am, I've got a couple of patient examples. So I am an avid reader. So whenever I go to a patient and they've got a book on the bedside, after I've done my work, of course, I always say, oh, what are you reading? What's your preference? And we had a lady that just, every time I walk past the room, she's like this, like a fish. It was like, just, what's the matter? And she said, I love reading. And I said, well, you've got some books there. And she said, they keep giving me Mills and Boon and I love horror. So I went down to our health and ageing library and I found her some gruesome books. But I just think, again, that's just listen to what they need. And then she just was happy then to sit in it with her time. This lady was actually waiting for a palliative bed, and she sat there for a long time because they can take a long time to come, and she just was miserable when actually just some small things can just make that difference. I've done the same for a gentleman last week who was in isolation, and he wanted to read war books, so we went and found them to. But I just think that also helps with the delirium, just to normalise your environment, a radio and a clock, and get them up. And the other thing I always question is, probably for someone like Caroline and Narangi, not Narangi because she didn't take any medication, but maybe Caroline. Even that 72-year-old physio I talked about before, we come in and we take all their medications off them, and why can't they do that themselves? And then after 14 days we go, and we've added 5 more, goodbye. So I always think around medications and that discharge home is always, we probably need to spend a bit more time. Bring the pharmacist on board and just spend that little bit more time. Can you still hear me at the back, Naomi? Yeah, all thumbs up. She hasn't fell asleep. I'm doing okay. So, and also what Joe talked about was like rehab's 24/7. Like I used to love it at weekends. Sorry, doctors, but you left. You didn't give us anything to do or interrupt what we were doing, and then you can just crank the radio up a bit and just have that bit of banter and just normalise life and talk with your patients about that. So I think for us nurses, that weekend time is just a key opportunity. You get to know your patients really well, I think, at the weekends, and then we become an OT and physio as well. Although we all know, and after a long, what do you call them? Public holiday. I was going to say bank holiday. Public holiday weekend, we'll still get. Oh, they never got out of bed for 3 days. So I just think that weekend time is so important for us nurses. It's just that quality time with all the other people gone. My last one is the patient's perception is not always our perception. We, and again, it's because we jog on with we've got health knowledge, but again, it kind of links with our knowledge is power. So I had a lovely lady in the first lockdown in March 2020, and I rang her for a 120-day follow-up, 93-year-old. broken a hip. And I said, how are you doing? We're just ringing to check you're all right. Oh, awful, I'm never going to get back to what I was doing. I said, why? I'm still using the frame. And I was like, well, that's, you've got home, lots of people haven't, and I can't, I'm just, no, and I thought, how do you get a physio out in lockdown? I've never done this before, and how do I get an OT? And so I'm at home, writing all this down, and talked to her for about 20 minutes, and I said to her, look, it's a beautiful day, just open your back door or your front door and just feel that sun on your face. And she said, oh dear, I've taken all the apples off my apple tree this morning and I've got four apples. And I was like, hello, you just said you couldn't water. Well, I had to do it with my frame. So, her, I was thinking she was dire, and her perception was that she had to, is the right word, shook an apple tree with a frame. When actually she's doing marvellous. She's 93, she didn't know home, and she'd emptied 2 apple trees and she was boiling them all on the stove. So yes, so I think our perception, I told her she was wonderful in the room, but our perception is very different from the patient's. I've also got let's have a look, I'm writing down. Oh yeah, so me and Nick at the back there, the ortho-geriatrician that I work with, we had a lovely lady a few weeks ago, 61-year-old lady who broke a hip. Shocking, 61. Shouldn't be happening. She'd prior broken an ankle. Both incidents of fracture were alcohol-related. And so me and Nick gave a lovely talk about, her bone protection and that she should reduce the drinking. And she nodded and said she would do all of the above. And so this lady, this boggles my mind, this lady doesn't drink tea and coffee. She pours her wine like the milk for tea and coffee and then tops it up with a bit of water all day. That's her intake. And then at weekends, she gets, quote unquote, I get on the bourbon and cokes with my daughter. I don't do wine at weekends. Anyway, we were like, anyway. So this lady nodded and said all the right things to me and Nick, and then promptly left. 2 days later, we think because she needed a cigarette and she needed a drink. So I've rang her and no, she's not. Her bones are fine, and she's not. And she's not going to take anything, and she's just staying at home for now. So my perception of her is, oh my God, we need to get everybody in there. We need to get the physio. She's 61 because she needs to drive a car, and her perception is life is all right because she stopped drinking the wine in the week. And I don't know how to change that, but that's her. How do we change that perception? But that is her perception for her, and I think again listening to the patient and what they need to do. Obviously, me and Nick know we will see this patient in the next 3 years again with another fracture, but we've done our very best. But that's her perception of how to make her life a little better, even though she's listened to us. So yeah, I just think we just assume that they know everything that we know and what that means. I know what that means to that lady by the time she gets to 70, but we don't, and that's for, she's not worried about that, but the health professionals are. So very different perceptions, and I just think we very often forget that. And that's me. That's the end of my waffle, apart from to say, yeah, it takes a village, it's a team approach to everything. So a little bit by everybody does well for that patient. Okay, thank you.